Hi guys, I'm Dr. Yusuf from Cornwall, Ontario, presenting to you this patient with the bilateral cataract. The right eye is hypermature, so I'm going to start with the left side first. I'm starting with the femto part. What I'm doing now is just activating the laser machine. It has to scan the RFID of the liquid optic interface that we use for the patient. So what I'm doing now is just applying the lens, which is going to be attached to the laser to be able to scan through it and laser through it. You notice that I'm hanging my Apple Watch upside down from my pocket. Just always want to check the time and any messages. So now the tubing is attached to the laser machine, and the ring I'm holding in my hand now is the liquid optic interface, which is going to attach to the patient's eye later. I'm going to verify the laser settings and start activating the laser. Unfortunately, you don't see the screen of the laser behind the laser machine. Now what I'll do, I'm going to wet the lens of the laser. This will break the surface tension and allows the water to fill this chamber later without having air bubbles, because when you have air bubbles you have to undock again and dock again, so which wastes time. So I'm putting the strap on to stabilize the head of the patient. I usually rotate the patient's head slightly away from the site we are doing during the laser and toward me when I'm doing the actual cataract surgery later. So I'm starting with the left side again because it's a milder cataract. So I'm applying the LOI to hold the patient's head, the eye, and the lids open. And then after the suction is up and running, now I'm filling it with the balanced salt solution or saline here. Now I'm rotating the patient's bed to be under the laser, and we lock the bed in place. I'm raising the patients up to the laser to couple the LOI with the lens attached to the laser machine. Then we do capture of the laser, and then the laser will start scanning with OCT, finding the different layers of the eye, the cornea front and back, the lens front and back, pupil and limbus. So all the landmarks of the eyes are outlined with the laser. And after that, they will go through the plan and start the laser afterwards. So that's what I'm doing now, and just verifying that the laser I have actually identified every layer properly, because this will be the target of the laser afterwards. So now I'm depressing my foot switch, and the laser is firing. Starts with capsular X's, and then the nuclear softening. Here I just divide the nucleus into 6 parts, and then goes through the wounds and the LRIs. This patient needed a toric lens, so I marked the position of the lens with the laser, just to be able to align the lens properly later. Now the laser is done. Rotate the patients out and put the bed up, because I use the same bed for both the laser and the cataract. This is efficient that way. So I lock the bed in place and put the patient to the maximum height. I remove and discard the lens and tubing, and then we start the cataract surgery itself. So you have 2 views here, the GoPro on the right side and the microscope lens on the left side. You can see that already the capsule X is done, and the nucleus is divided into 6 quadrants. I wash the cornea with balanced salt solution to remove any debris from the when the patient squeezes their eye a little bit, they squeeze meibomian gland secretions, and they become oily in the tear film, so just wash it as much as you can, washing out all the debris. You can see some subconjunctival hemorrhage around the redness here, and this is from the suction ring of the laser. So this is the Thornton ring to stabilize the eye, and I do a 2.75 incision in the temporal part of the cornea. It's clear cornea, and then we inject a mix of lidocaine, 1% preservative free, mixed with phenylephrine 10%. Then we use endocoat to fill up the chamber, and at that time I actually make sure that the capsulorhexis was done completely by the laser, which is 99% of the time is usually complete. And then I cover the cornea surface with the endocoat, so nobody needs to keep putting balanced salt solution on the surface of the eye during the procedure. Now I use a smaller knife to the side, and I open small incision, usually it's about 0.9 millimeter. It's 80 degrees to the left of the main incision. And then I'll do the hydrodissection, hydrodelineation, and nuclear rotation. So here with the Femto, you have to hydrodelineate very well each quadrant, because now the lens is divided into thirds. So it's not enough to do one part and it goes all around. You have to actually rotate the lens and hydrodissect and hydrodelineate every part. And here I make sure that the area opposite of my wound is very, very well hydrodissected, and this will help with the J cannula later. I use the signature white star from J&J. I'm just adjusting the silicone sleeve around the phaco tip. Sometimes the phaco tip comes from the side. So now I'm using the chopper. It's already chopped, so I just split the openings and just remove the quadrants that are already almost free floating. This is a +3 cataract, nuclear cataract. The other side, the right side, will be hypermature cataract. It's intumescent. So I'll just eat the thirds one by one, and then remove the epinucleus. I keep the epinucleus till the end, and even if it wants to come out early, I just put it back. I want this protection for the capsule, so I keep the last thing to remove the epinucleus at the end. This is still the last quadrant, and then the epinucleus is removed. Now we're gonna go in with the J cannula. So I want you to notice also my hands. So look at the left and right side and stop the video if you need to. I go to across and then find that opening and just irrigate the fluid out. You can see that the cortical material is just coming out of the wound through this irrigation. This will result in a very clean capsule, and even the fornix of the bag is also cleaned that way. And I cleaned the subincisional area too with that. When you come out, just make sure that you're horizontal very well so that it doesn't poke the wound coming out. Now I'm injecting the Elon, which is the cohesive viscoelastic. To implant the lens. So the lens is a toric lens. I'm actually folding it at this stage on the side table. So I'm not sure if you can notice the small dents on the cornea from the laser marking of the toric for the toric lens implantation. It's not very visible, but they are there. I can see them on the microscope. I'm just making sure that the lens is inside and the haptics are in good position so they don't get caught in the injector. So I usually hold the eye by holding the side incision and then injecting, making sure that the lens of course is in the bag, and later I'll position it to match the cornea markers.
Nice colors, huh?
Yes.
Now I'm going in with the irrigation aspiration to remove anything. Now I'm using the lens as a shield, so I'm gonna remove any cortical material that's left behind, clean the capsule by moving the lens with me, so it's always protecting the capsule from my irrigation aspiration. So while I'm doing that, I rotate the lens, make sure it's in good position in the bag.
And look at the
And
light.
I'll use the hydrosection cannula on the 10cc syringe. I irrigate behind the lens, rotate the lens, and I irrigate also in the anterior chamber in the angles. So it goes sideways, so if there's any pieces hiding in the angles, will come out with this flow of irrigation. So I'm still positioning the lens. This is an unedited video. I didn't speed it up. I'll just show you the real thing without editing. I just mask the patient's face and just for privacy. Positioning the lens, making sure it's staying in good position along the axis of the markings. This patient was seen 2020, about an hour after when I did the postal follow-up the same day. She was seeing 2020 out of this one and 2025 out of the other one, which is the hypermature cataract. And it's she had a perception of light vision before the surgery. Now I'm hydrating the wound using moxifloxacin. So I don't use BSS for that. I use moxifloxacin because the moxifloxacin you inject inside the eye can actually wash out really quick, but if you inject it into the layers, it stays much longer. And I do the dropless injection, the trimoxy, triamcinolone and moxifloxacin with some xylocaine so that the patient doesn't need to use drops after the surgery, the dropless cataract surgery or no drops cataract surgery. So now I'm just removing the patient squeezing wall, so she's capturing the speculum. Now it's done. So now we're gonna get ready for the more difficult one. I started with the easy one and now I'm going to the more difficult right eye. This is hypermature cataract, so the chamber is much shallower than the other one. The lens looks like a balloon, and unfortunately I didn't show the part where the laser was scanning it and how big is that lens, and what happened when I did actually the laser, when the capsule became free floating or the capsulotomy was done. It's actually you can see a pop of fluid because of the pressure, how much pressure is inside the lens. And this is the best value for the laser, is to do these kind of eyes safely, doing the rhexis in the safe pattern like that. So I'm again putting the lens on the laser machine, and I'll put the tubing. So this is a new set. Of course, we don't use anything from one eye to the other. Everything is separate completely. That's how we can safely do bilateral surgery without fear of having complication in both eyes. I always struggle with putting this. I think this cartridge has to be modified a little bit to hold this LOI very well. I think it's not holding, it always wants to fall. It doesn't fit it very well. So what I'm doing now is I'm just drying the skin around because we just put the xylocaine gel, so it usually wets the skin and you can't get a good hold of the lid. So you dry it out very well before doing this next step. I'm just activating the laser to start the suction. So I'm inserting the LOI again. And with the foot switch I will start the suction to hold the patient's eye. Unfortunately my nurse didn't notice the camera, so he's standing in the way. But here I inserted the LOI, holding the patient's eye stable and holding the lids open. You have to make sure that there's nothing interfering with this suction, because otherwise you're going to lose suction during the procedure and you don't want to have that done. So after I move the bed under the laser, I would lock the bed in place and then start raising the bed into the laser, the lens. This will couple the LOI with the lens and the laser, and it will capture it. And then you have to verify there's no air bubbles and start the scanning. The OCT will scan different layers of the eye, cornea, iris, pupil, lens, front and back. And it will keep a live feed of that during the surgery. So it takes the whole laser procedure from starting the suction till the end is about 2 minutes approximately. So after the scanning is done, I activate the laser, start by doing the capsule axis, dividing the nucleus, then the wounds and the LRIs at the end. So at this stage, it's just comforting the patient, telling them everything's good, and they shouldn't talk and move at all during the procedure. And just I'm putting my hand on the patient's head to adjust any tension, because laser gives me feedback of where the tension is going, and adjust that by moving the head slightly. And this gives the patient comfort too, that I'm still there, I'm still touching them, and it's very important to do verbal anesthesia during that part. Or throughout the surgery, actually giving the patient feedback and comforting words, and keep that throughout. So after the laser is done, we release the suction and the coupling, and just move the patient out, raise the bed, and start the cataract surgery itself. Again, this side is a much more difficult eye than the first one.
The difficult part of your kind of cataract.
So I'm raising the bed. Again, this is an unedited video, so that's why there's some steps that you might not want to see in an edited video, but I want to show the whole thing. So sometimes the ironed out kind of video shows you unrealistic procedure, because it removes the difficult part, or the part that you might be facing when you do that surgery alone. So I'm done the laser, I'm just covering the laser tip and shutting down the machine. She was the last. I usually keep my most difficult patient until the end. So this is the most difficult eye, the most difficult patient. I kept it till the end, so I shut the laser afterwards. So you can see the subconjunctival hemorrhage. This is from the suction ring. can see the hypermature cataract. It's very dense, not just white. It's brown in the center, so it's a very tough cataract to do. I'm really glad that we have the laser to help us out with these kind of difficult cases. Although the laser already did the capsulexes, I always, because I'm obsessive compulsive, I usually still do the vision blue to verify it and help if I need to complete the capsulexes, which is unusual, but in this case actually was slightly attached, so I had to actually use the capsulexes forceps to release the rest of it. It was already done, but I had to just go around it to make sure it's okay. So I'm finishing the setup, that's why there's nothing visible here. Because while I'm doing the first eye laser, the nurse is setting up for the cataract, and then so it's efficient that way. So starting the routine things, so the ring and the 2.8 or 2.75 millimeter incision. And the next step is to do the vision blue. So you notice that I'm using a cotton tip actually to push the plunger of the vision blue, because the plunger was loose and I dropped it on the ground. So I used a cotton tip just to push the plunger tool. You have to learn to modify your surgery based on what you face. So I injected the vision blue, and then I'm washing it out with just BSS. Sometimes you can put an air bubble and you can inject the vision blue inside the air bubble, but I usually just inject it straight to that area. Now I'm injecting the xylocaine preservative-free with phenylephrine to enhance dilation. She also, just to add to my miseries, the pupil is not fully dilated too, doesn't dilate too much more than that. So this is the endocoat to inflate, and I use it to also to cover. But you can see here I'm trying to verify the capsulexis is complete, but I found that this area where my tip is didn't seem to be complete in this area, or it still had some tags and attachments. So that's what I'll do with the capsulexis forceps, just to do it under control. But most of the cases are usually complete. So I'm doing the second incision, 0.9 millimeter in size, usually the internal. I did it more closer to the center this time, because this is a very thick cataract, and I want to be able to go in with the chopper and reach the back of the lens. So I did it more central. You can see completing the rexes, and now the laser is complete, and it's out. In other cases, if without the laser, this will be a most difficult stage, and we worry about the FLACS sign, the Latino FLACS sign, where the just lens almost explodes immediately. So I'm doing the hydro delineation. There's no much hydro section here, because the lens is really looks like a rock. There's not much cortical material left, very minimal amount, which is mostly just becomes liquid, and this is the one that's making the eye to be intumescent, and it's to be inflated that way. So for hard cataracts, I usually do a little bit of debulking in the middle, just to be able to decrease the sizes of the pieces. So it was a long process. For these cases, I just take my time. I'm not in a rush at all. When you rush or lose your patience, that's when you get in trouble. But just take your time, no rush at all. And patiently remove the pieces. I'm debulking a little bit here. The problem is usually in these cases we have the big, thick plaque in the back. So that's why I did the second incision a little bit closer, more directly to the posterior, so I can actually reach to that part without having to torque the cornea too much. I find that the most valuable part of the laser here is actually to create the capsule rexus safely. Here it's not much softening because the cataract is so hard anyway. There's no much division actually that the laser will do, but it's mostly the capsule rexus, which is the most critical part of the procedure. The rest of it is just you have to take your time and divide the nucleus bit by bit and watch for this plaque in the back. And see here it's divided. I was able to get the first piece out. Again, it's a long, I didn't edit the video. I didn't want to speed anything up, so just to let you see the whole thing as it is. So most important thing is just you notice that I'm doing this on the pupil level. I'm staying away from the pupil edge. I'm dragging all the pieces to the center of the pupil and do it all there. So it's away from the cornea and away from the pupil edge, away from the rexus. So drag the piece and do it there, and always have your second instrument either pushing the pieces in or protecting the capsule, so behind the piece. So half of the lens is gone, dividing the other half.
Everything is going well. I'm just taking my time. Okay?
So one piece
Quite
came out and still eating it up in the center of the pupil again, away from the cornea. You don't want to end up damaging the cornea and having corneal swelling, so very carefully those pieces. Don't lose your patience. If you lose your patience, you'll rupture the capsule and end up with a major complication. So take it easy, slow, deliberate. In the center, watch your location. So now the most difficult part is the last piece, because now you don't have any other pieces holding the capsule back. So sometimes what I do actually, I stop and just inject some viscoelastic behind. I don't find that that's necessary as long as the chamber is stable. You have a good phaco machine, so the chamber is stable, and you have you see the chopper is behind my phaco tip. So the most important thing is the chopper is behind the phaco tip, so you don't capture the capsule. And now it's the most painful part is done for me, not for the patient. And I can breathe now. Now I'm using the J cannula. Usually with these hard cataracts you don't have much tissues left to irrigate, but I still do that, of course, to irrigate the pieces that you don't see. You notice that there's some swelling around the second incision from the manipulation you're trying to reach with the chopper to places that you don't usually try to reach to. And it's more central, so it's more visible, but the swelling goes away really quick. So J cannula is done. I love the J cannula. It saves a lot of trouble. So now I'm inflating the chamber and the bag with the heel on. I'm folding the lens, so it's gonna take me a minute or so to fold the lens. I'm just working on the side table, you don't see that part. So this is a toric lens again, and it's the marking on the cornea, you don't see them, they're very faint, so they're not very visible, but I see them under the microscope. So I'm planting the lens again, making sure that the whole lens is in the bag, of course. Sometimes with smaller pupils it becomes more difficult, and sometimes you find that one of the haptics it will end up in the sulcus if you're not careful. But you have to verify that in every single case. Make sure those lenses are going into the bag, nothing in the sulcus. So the lens is in. Now I'm gonna need to rotate the lens, make sure it's in the bag. Yeah, here we go. So sometimes the corneal marks might not be very visible until you wash the cornea from the endocoat that you had on it. And you notice that the endocoat was staying throughout the surgery. No, I did not need to score the cornea, not a single time. I like the endocoat doing that. Helon and Helon GV is not suitable for corneal wetting because it takes a very long time to disperse on the cornea because they are cohesive. Endocoat is dispersive, so it disperses itself and covers the cornea well. So I'm rotating, I'm using the IA to inflate the eye and then rotating the lens to match the corneal markings. So wash the cornea. Now I'm going to use the hydrosection cannula in the 10 cc syringe. I wash the cornea, I wash the inside, make sure that it's washed out, and I always irrigate behind. I don't go with IA behind the lens. I go with the irrigation and irrigate behind the lens, which washes out the oil, everything behind the lens. I'm washing the endocoat from the cornea, hydrating the wound. But most of the hydration of the wound would happen with the amoxifloxacin. This is 160 microgram per ml and injected into the cornea, more towards the outside of the wound, so it's more toward the sclera. Okay. And I'll inject the Dropless, the Trimoxy, in the subconscious space. And that's it. Thank you for watching. It was a difficult case, but went well.